Thank you, Jeremy, and thank you to Google for doing this today. It's such an important time in the AIDS response to have HIV squarely on the radar. So it's really great that we get to do this in Google headquarters. We've come a long way, as Jeremy was saying, in the AIDS response, but of course we have a long way to go. About half of the people that we have wanted to reach with prevention are reached, and about half of the people on treatment that we've wanted to reach are reached. So I'm going to start with a question to you both, which is just a general question about, in this moment where we've made so much progress, and it's actually a bit of a confusing message that we give people. We have proof of concept that we can control the virus, that we can treat people effectively, that they can become non-infectious when they're virally suppressed. And we've made incredible, incredible strides in many countries and many regions of the world. But in other places, it's like 1981 all over again. People are too afraid to come forward. They're not getting the treatment that can save their lives or protect them from getting HIV. So what's happening? Why do we have this duality?
Well, I mean, I would say it's not even other places, right? It's kind of every place. Those two messages are competing. And I think that makes it particularly challenging to be able to convincingly express both of those things at the same time, right? We're doing great. And we have all these effective prevention methods and ways to treat the virus and to keep people healthy. And at the same time, you want to keep the message going that people have to engage in those prevention methods, and you have to keep people sort of motivated to get themselves tested, to get themselves treated, et cetera. I mean, I think one of the challenges is that we spent so much time at the beginning of the epidemic scaring people for good reason, right? It was legitimate public health messaging, but we did spend so much time and energy there that it's now hard. One, we created a lot of the stigma that exists today, and now it's hard to send a different message that's about, oh no, we can take care of this. You can live a full, complete life, and it is not no longer the fatal condition that it was if you come and engage in this treatment. So it's we spent a lot of money at the beginning, and we're not spending as much money now getting out this other message. So
great. And Patrick, in your part of the world, you are in the Central African Republic. What is, the bulk of the infections are obviously in sub-Saharan Africa, but throughout Africa, we have lots and lots of people that we're not reaching. What are the challenges that you're seeing there?
Thank you, Regan. For me, really, this where we are today speaks very clearly to the disparities in the world. And that looking at disparities is not just geographical. Within our own communities and societies, we can see that HIV is affecting different people differently based on whether they are part of those who have or those who have not. The epidemic is telling us something very clear and very strong about inequalities and discrimination. And this is what we are seeing through the pattern of this HIV epidemic today, the fact that the majority of people who are in need of HIV treatment live in the global south. We've seen tremendous progress in terms of access, but still there is a lot to do. Today, those that we refer to as key population, these are gay men and men who have sex with men, sex workers, prisoners, and people who inject drugs, people who are not necessarily at the center of our societies, but are rather being marginalized and kept at the periphery, are those that are most affected by the HIV epidemic globally. They represent half of all people living with HIV. In Eastern Europe, Central Asia, the Middle East, and North Africa, key population represent about 95% of all new HIV infections. This tells us something so important about how we treat others, about who is at the margin, who is at the center, and this is what our message should be about. This is the unfinished business of AIDS. It is a fight that we have to continue around inclusion, non-discrimination, and justice.
Thank you. Yeah, it's amazing. I want to turn a little bit to the stigma. So I was diagnosed 23 years ago, and I went from not being in a marginalized part of society to being overnight, in the underbelly of society. People disliking you, fearing you, dismissing you because of something that happened to you or was a fact about you. And often when I speak to kids in high schools and even grammar schools, I say, I didn't do anything wrong. I just encountered a virus. In fact, I did something that everybody's mom does or did. And, at the same time, when I did it, there was a virus present. When other people did it, the virus wasn't present. That doesn't make me a bad person. That makes me a biologically unlucky one. And I think we've, in our focus, which is right on all of the people who are being left behind, we, I think, have created an idea around this disease that it's about certain types of people or certain types of behavior, when in fact it's just a biological agent. It's just a virus, and it will be opportunistic and go everywhere it can. We focus a lot on disenfranchised people because they are not coming forward and we are not reaching them. But in this moment in the epidemic, this is our work, right? Because we've reached the people who are easier, the children, the babies, the mothers, and now we have to reach the other people, because if we don't reach all people living with HIV, we won't actually end the epidemic. So stigma and discrimination, what do we do about it? I know this is a big focus of your...
Yeah, that's a huge question. Your question sort of popped so many things in my mind. One of which was, you were saying about you felt like you were sort of in the privileged group, and then suddenly you were in the marginalized group. I actually think that is what sparked a lot of what ACT UP did, right? We were talking about some relatively privileged folks who really, for the first time, even though they were gay, they could be sort of invisibly gay. And they weren't out necessarily, and they could kind of maintain their privilege. But when HIV/AIDS struck, suddenly this group that was used to having a certain amount of privilege was in the group that was then marginalized and not being taken care of. And the problem wasn't being addressed by the government, and their reaction to that was very strong and very vocal, right? And so that drove a lot of the I think, advocacy at the beginning of the epidemic. And I think that then the next phase of that, or the next big step, was when we got access to treatment. And the first people that actually had access to treatment were some of those same privileged folks. And what we saw after 1996 and going into the early aughts was people sort of going back in the closet with respect to their HIV status. And I see a lot of intra-community stigma that goes on. People think about stigma coming from the outside, right, and affecting the group. But one of the things I think we haven't addressed within the gay community very well is the amount of stigma that exists between gay men over this issue. It has changed tremendously with the introduction of PrEP and the understanding now that U equals U, undetectable equals untransmittable. And so it's shifting, but it's been a long time coming, and it's not shifting that quickly. And so it'll be interesting to see, how this plays out over time.
Thanks. And PrEP is pre-exposure prophylaxis, for people who don't know, which is
right.
medication that you take in advance of exposure to HIV that can prevent HIV. There's also use for it within the 72-hour window after potential exposure, where you can reduce your chances of contracting HIV. Patrick, stigma and discrimination, better or worse in Africa, where people are very familiar with HIV? And how does the fact that now when people are on treatment and they're adherent, which by the way is not easy, you have to take almost every pill every month to achieve viral suppression, to achieve complete adherence, which will in turn suppress the level of the virus in the blood to an undetectable level, which means that you can't transmit the virus to somebody else, whether that's a baby or a sexual partner or just other ways through injection drug use or breastfeeding. But tell us about what's happening in Africa and your other parts of the world that you operate in. Is it the same as we're seeing here in the United States?
It's generally very much the same, actually. When we talk about stigma and discrimination as it relates to HIV, we need to, of course, realize that there are various natures and type of stigma and discrimination. Some of it happening at community level, in families. Some of it is internalized. But all this thrives and all this happens because of an overall environment that sustains, maintains, and lets discrimination thrive and let stigma thrive. And let's look globally. Today, there are 35 countries across the world where people living with HIV are denied entry, residence, or stay just because they're HIV positive. Across the world, it is estimated that some 75 countries have laws that allow for the criminalization of people living with HIV. again, it's just because they're HIV positive. In the case of HIV exposure, non-disclosure, or alleged HIV transmission. Let's look around, again, across the globe. There are many places where same-sex relations are criminalized, more than 70 countries and territories that have such laws. And this environment is what makes stigma and discrimination so effective. And so if we talk about addressing stigma and discrimination, we have to be able to challenge this overall legal and policy environment that lets stigma thrive. And this is what UNAIDS and other agencies are trying to do, working closely and together with civil society folks like Scott here and other colleagues across the world that are working hard to address stigma and discrimination. This work takes the form of legal challenge in some countries, of mobilizing. Jeremy, in his introductory remarks, spoke of ACT UP, a wonderful key group that help unleash the power of communities to challenge stigma and discrimination and inaction on the part of governments. And so we are all in this and have to realize that there is something that we can do to address stigma and to address discrimination.
Great. And did you want to add something?
Yeah, I just wanted to follow up because you said the thing about the treatment adherence and how difficult it is. And I want to put a little gloss on that because I think that one of the things, and again, this is these dual messages that we need to send, because really it's the things that the other aspects of a person's life that affect their ability to be adherent, right? And it's things about unstable housing, right? Or food insecurity, lack of transportation, all these other things that right, being displaced, that go into, that make it difficult to adhere, and which is why the virus continues to progress in communities that are marginalized in those ways. And the reason that I thought about this when you brought it up is I'm actually doing a case right now against the U.S. military. And trying to convince the U.S. military that indeed they don't have to have these restrictions against people living with HIV serving in the military. And one of the things that I've learned during this process is that in the military, their viral suppression rate for active duty service members is 99.8%. Well, what is behind that? It's about those are folks who do not have unstable housing, who do not have food insecurity, right? They've got all the social supports to be able to take their medication on a daily basis. And so I think we have to draw that distinction. And again, it's hard to send both these messages at the same time, right? That we have a problem and we need to address it. And yet, once you have the solutions in place and the supports in place, it's really not that hard, and the prognosis is actually fantastic.
Right.
So, yeah.
Yeah, no, that's very helpful. And I just come back to something you said about criminalization. You know, so diagnosed in '96, given a year, 2 maybe to live, and then I don't die, and I keep going, and the medicine keeps getting better. I used to take 16 pills. Now suddenly I'm taking, 10 years later, just a couple of pills, and now today I only have to take 1 pill. But just about the time I got comfortable with HIV and stopped self-stigmatizing, because that's another thing too, the shame that you feel because of people's perception of this disease and how you look at yourself. But just when I thought I was out of the woods and I might make it and live a long, healthy life, I started worrying about criminalization. And I think that's a really undervalued barrier here. I mean, I think it's something, whether it's perceived or real in all countries, the idea that you could go to life in prison for non-disclosure or alleged non-disclosure, this is a difficult thing to prove, is really frightening. How much, and also we have legal issues around LGBTQI people in all parts of the world, but how much progress are we making in that arena, and how important is it to make it a peaceful legal arena for people to help us get them to come in for treatment and prevention?
Yeah. No, clearly, this is a struggle that we continue, but we have to pause and realize how far we have come. And the fact that we are seeing tremendous progress in spite of the challenges. And again, the duality of the message is here and very clear. In the past few years, we've seen people living with HIV and the allies, entities like my own organization, UNAIDS, governments working together to bring the issue of criminalization alive and call for change. And just early this month, the Constitutional Court of Colombia issued a decision in which it found that laws that allows for criminalization of HIV transmission and hepatitis B transmission was ineffective, unwarranted, and quashed the penal code provision that allowed for it. And we are seeing similar things happening in different parts of the world. And this is first thanks to the work of civil society groups like Lambda Legal here in the US, but also groups like HIV Justice Worldwide, which is a coalition of civil society folks that have come together to challenge HIV criminalization. Last year in July, these groups of civil society, together with UNAIDS, the International Association of Providers in AIDS Care, and the International AIDS Society, convened a group of 20 of the world's leading HIV scientists, including a Nobel Prize winner and co-discoverer of HIV. Together, those 20 scientists came to look at the evidence around HIV and the criminal law. And what they say was very clear and almost definitive. What they say is that the way the criminal law is applied to HIV often is driven by stigma, and this has to change. They clearly called for the criminal justice system to ensure that any application of the criminal law is based on the best available scientific evidence, and they even went further to say that the positive impact of HIV treatment needs to be recognized by criminal justice actors, and that undetectable means untransmittable. And so this is so powerful, and it shows that there is progress. But at the same time, there are many other parts of the world where this progress is not sticking or is not going as far as will be needed. And this is why we need to continue this work. I think being here today talking about those issues is important, but we need to continue this messaging, and we need to continue supporting the various groups, civil society and others that are doing this important work.
Great. And I was just going to say one quick thing.
Yeah, go ahead.
So when I was diagnosed, I called Gay Men's Health Crisis because that was the organization that I'd heard of the most in connection to HIV. And I called up and I said, I'm not gay and I'm not a man, but I'm totally in crisis. Will you please help me? And they were amazing. They were amazing. But I think about what you're both saying, and in this moment, how we need to bring back some of the action and the energy and the urgency that we had in the early days, and the expertise, quite frankly, of many of the civil society groups who led the charge, who saved my life, all lives of people with HIV who are on treatment, and help educate the civil society groups who are coming up today, the young people and people in other countries where they don't have as much of an infrastructure of civil society that we have in the US. So could you talk a little bit about how we can blend those things?
Yeah, I mean, might be a better question for Patrick in some ways, because he has a better sense of the global situation, right? And places where, as you say, the infrastructure is not as good. I mean, the issue has definitely faded from the public consciousness here in the United States, and that has also been true among the very groups that really led the charge at the beginning. I mean, I'm very proud that Lambda Legal has been in this battle since the beginning and has never let up. We brought the first HIV discrimination lawsuit in 1983, and ever since there has been a dedicated effort and now a project at Lambda Legal focused on this. But as I said before, when the epidemic was no longer affecting some of the most privileged individuals who are also some of the folks that were leading these efforts, funding these efforts, it faded a little bit in the list of priorities. And so I think we're at an important point now to really to bring it back and to put it back at the forefront of what we're doing, from LGBT organizations, from women's organizations, from organizations of people of color, et cetera. I think it could be at the forefront of more of them, and that would be really helpful. I wanted to mention, Patrick was talking about the HIV criminalization. It's been something that Lambda Legal's been involved in really, the whole time I've been there a dozen years, and before that. And I think it's really important that we send the message that it's a public health issue, that this is, first and foremost, these HIV criminalization laws are affecting our ability to get people to step up and to get tested, to remain in treatment, to remain adherent to their medications. If you're trying to hide your HIV status from sexual partners, well, then there's a chance that you're not going to take your medication with you and you go on an overnighter, et cetera. So these laws have effects throughout our ability to impact the epidemic. But I also think it's important that we don't let our response hinge on whether or not a person has an undetectable viral load. We can't let that become the dividing line between who is prosecuted and who is not prosecuted. And there's a real risk of that happening. We're already seeing some states in the United States that are moving in that direction. And that is really problematic. We have to get to the more fundamental idea that it is simply wrong to criminalize a medical condition. And that is not the response that we want or need to actually bring people out into the light, bring them into treatment, and get a handle on the epidemic.
Yeah. No, and I think really your comments gives a great transition into what I wanted to say, which is that recognizing and placing people living with HIV at the center of the response has really been what has made the response to HIV so effective. And criminalization and other laws and policies that target people living with HIV, that push them at the margin, is bad for the global response. It is damaging for public health, and it is not right from a human rights perspective. And so talking about what communities are doing and how we need to create space for them to continue coming forward and working in this area is very important. If you take a country like the Central African Republic, where I'm currently working, people in HIV are working there under tremendous challenges. A review of the Stigma Index, which is a study that is done by people living with HIV to see the extent and degree of stigma in the communities. The Stigma Index result in the Central African Republic show that 85% of people living with HIV report having been discriminated against or having faced stigma. This is a clear and very overwhelming challenge. Yet, in spite of all this challenge, we see on a daily basis people with HIV coming forward, monitoring access to treatment, looking at where stockout is happening, looking at who is not reached by services, and actually speaking out for more access to HIV services. And this is important. And these are the voices that we need to maintain in the response, not shatter them through ineffective and irrelevant policies. And this is very, very important. And of course, you raise the issue of complacency in the global HIV epidemic today. It is clear that we've made fantastic progress. Let's just remember that in 2000, there were less than 100,000 people on antiretroviral treatment in middle and low-income countries. Today, in South Africa alone, there are 4.5 million people on antiretroviral treatment. In India, 1.2 million people are on treatment. In Brazil, more than 550,000 people are on treatment. Many would have thought this totally impossible just 20 years ago, but we are there. But this clearly should not lead to complacency, because overall, we are not reaching about 40% of people who need HIV treatment. Today, we are facing a situation where HIV prevention is in crisis. In the past 7 years, we've seen a very limited decrease in new HIV infection. Just in 2017, 1.8 million people became newly infected with HIV. This is a crisis. And so we should not be complacent. The job is not yet done. And there is a clear need for continuing pushing for this HIV response, funding money to finance the treatment programs, to continue pushing for HIV prevention. It is estimated that in 2020, the world will need about $26 billion to fully fund the HIV response. We are far from these numbers, and we need continued energy and continued drive for the HIV response.
Can I add to that? Because I think sometimes people hear about the global epidemic and they kind of separate it out from the US epidemic. One, we're part of the global epidemic, but also we also struggle in the United States, a country that is resource rich with getting care to all the people living with HIV. And I think people don't even realize that about 14% of people living with HIV in the United States don't know that they're living with HIV, and that the number of people who are virally suppressed is somewhere around 54%, I think, of people living with HIV. So we still have a ton of work to do here in a very resource-rich country we don't, because of the healthcare system that we have, we don't get people into care, and that's still a problem here as well.
Well, what we are seeing and what I'm hearing you both say and what we know is that we've got the tools, we've got the knowledge, we know how to do this, but we can only reach half of the people to date. So to reach the rest, we have to remove stigma, remove discrimination, address criminalization, get that solved, and humanize the disease so that people see people living with HIV as people living with HIV, not as someone who did something or didn't do something, or just a person who's in need of medical care, who has a biological agent in their body that can be controlled very effectively with medication, that can be prevented from entering the body very effectively with medication or other behavioral approaches. So, I'd like to turn to the audience in a minute, but how, parting thoughts here, what advice, you both have been working in this field a long time, we've laid out the issues. I'm a journalist by trade, so I'm always like, so now what? So what do we need to do? What do you think would be game changers in the coming years?
I think a shift to a focus on the stigma, right? The biomedical stuff, we got it. Like, it's all there, and we know it, and we can make it work. But unless you address the stigma and discrimination, you're not going to get the people to come forward. You're not going to get those treatments to them. You're not going to get those prevention technologies to them. And so I think a huge focus on that, and something that some other leaders in this field have battled around for years, is a rebranding. We almost need a rebranding of HIV. So that, as I was talking about earlier, we spent a lot of time and money sort of turning it into this very scary disease that people would then take action to avoid. And I think we need to rebrand it, and we need to talk about how capable people living with HIV are, how they really are no different than anyone else, except they have to take this pill once a day and go see a doctor every 6 months or so. And that if we can, as you say, take the blame out of the equation and make it about life and moving forward, that I think will be a big part of the solution.
I can't agree more. I think this now is the time to break barriers, to let agency, especially the agency of people living with HIV and those who are most vulnerable, come out and really show us the way forward. But it is also a time to close gaps because there are many things that are not working today in the HIV response. I've spoken about prevention not working. We are not giving prevention enough attention. That's the first thing that we need to do. The second thing that we need to do is, as Scott said before me, is clearly to take the blame out of HIV, is to take stigma out. But this is not something that you just say. There are things that we can actually do to end HIV-related stigma and discrimination. And we need to do those things now. It requires changing laws. It requires training for healthcare workers. It requires training for legal and judicial professionals. It requires empowerment and support to groups of people living with HIV, which today are faced with tremendous challenges with the funding. Funding for HIV groups is just not enough, and to a large extent is being decreasing over the past few years. And this needs to come back because these are the lifeline of the HIV response that we want to see and that we want for tomorrow. And the final thing that we need to do is clearly break the barriers, those irrelevant barriers between North and South, between West and East. We need to really create a global community to end this HIV epidemic, that a global community that feels concerns equally, because the epidemic of HIV is not just in sub-Saharan Africa, it is a global HIV epidemic, and the world needs to work together to address this epidemic.
That's great. And you reminded me of something that I thought about from the early days, survival guilt. Some of us who were diagnosed right on the cusp and watched our brothers and sisters die because they couldn't get access to treatment, it's still happening today. But I turned that in my own head into survivor responsibility. And the body of people living with HIV is such an untapped resource, I feel. I mean, first of all, we know how to deal with this, so put us to work, and also have often been helped by other people living with HIV. And I think if we could build a web of people, we're very safe. I'm not going to give this disease to anybody, ever. It's never going to happen. And I can help other people through those early days of the disease. And I think, you get your blood work every 3 months. And, I'm probably healthier, way healthier now that I have HIV than I was before. So, because I go in and now we talk about my cholesterol and all kinds of other things. He's like, you're just getting old. That's all that's happening to you. So I'm like, oh. But no, I think, and also, even with sexual partners, I make the point that I know what I have, and I don't want to get anything else, and I'm going to do everything I can not to get anything else, and I know how to prevent that. So in some ways, you're a safe bet with being a person living with HIV, which doesn't maybe seem like a logical thing for people, but...
No, I mean, I say this all the time, which sort of blow people's minds, or try to blow their minds, on, social apps and stuff, is that actually you're safe for having sex with a person who has HIV and is in treatment because... they know, and they are going to have an undetectable viral load, then you are having sex with someone who got tested negative a month ago and has had sex 3 times since then.
And doesn't know.
And may not know, right? If they, so it's a hard thing to sort of wrap your head around, but yes, you probably are safer having sex with the HIV positive person who knows it and is in treatment.
There's a T-shirt in there. I'm not sure what that is.
Somewhere.
I think I'd like to turn to the audience. I don't know if people have questions or comments. I can't see very well, so... Oh, now there's light. It's Google. There's light.
So I thank you so much for setting this up. This has been great. I just wanted to bring up a question about whether or not you think the epidemic today clearly is, fueled by a lot of stigma and criminalization, various issues. One of them being, in my opinion, would be also like drug prices. The privilege of being able to have access to drugs in the U.S. globally seemed like it would be lowered if the cost of drugs were lower, of course. And it seems like today, you can get to a drug regimen where there's just one pill and there's PrEP. If those things were vastly more available, it seems like stigma and the privilege of being treated would be much lower. And it would be easier to reach people because there wouldn't be as much of the stigma associated with it, maybe? I don't know.
Yeah, I'm not sure of the effect it would have on stigma, but it certainly would have an effect on our ability to fight the epidemic, right? If the drug prices were lower. It's a very complicated whole, set of issues, right? I think what the drug manufacturers would say, and this is sort of how our whole system is set up, was it's designed to promote innovation. Right? It's designed to, the reason we give people patents on things and allow them to charge these dollars is to force that innovation. And we have these amazing medications in part because of that very capitalist system that was set up. But then the question becomes, well, but how much is too much? And you then need to have, some governors on, yes, you want to force innovation or push innovation, incentivize it. And at the same time, when you've got something that is a public health such a public health issue and can have such tremendous impact on quality of life, do there need to be some type of governors on that? And other countries, do price controls and whatnot. We in the United States are reluctant to go in that direction. Again, our healthcare system is a little different. And, if we had a different healthcare system, you could potentially have the power to negotiate much better prices. So there's lots of moving parts to that, but I think you're absolutely right. If the drugs were less expensive, they'd be more accessible, for sure.
And I would just add that, given the scale of unmet need that Patrick described, both in terms of prevention, treatment, and the money, we have to find a way to make more of the drugs that are the newer, better drugs more affordable. We have affordable drugs in the developing world, but they're not the best drugs, which makes it I shouldn't say that. They're not the most current drugs that have the least side effects. They're wonderful drugs that are very effective. But I think that we need to be sensitive to the fact that if we're pushing for adherence to get viral suppression to stop the virus from spreading, we need to have people on drugs that they can take easily. And especially, we haven't talked a lot about children, but pediatric formulations, the ones that we have, need to be improved so that it's easier for young mothers to get these medicines into their children who don't like them. And maybe, Patrick, you could speak about the developing world drug prices.
No, I think the point that you made is very important, that new formulations that are easier to take, more effective, are today out of price for many people across the world. And this has to evolve. This has to change because access to medicine is is a human rights issue, but it is also a public health issue. We know how effective treatment leads to better life. It leads to it suppresses viral load so that people cannot transmit. So it has so many public health benefits. And so today, it is important that more people have access to newer drug, to newer medicine, and to more effective medicine. Children are a group that is particularly impacted. Today, we in some of the countries most affected, if you look at West and Central Africa, for instance, this whole region, about 26% only of children in need of treatment are having access to it. In the country where I work, it's about 25% only of children in need of treatment who have access to it. Clearly, issues of affordable medicine is one part of the equation, but there are also other issues that are linked and related to access that also impact, from inappropriate supply chains to the lack of ability of some certain countries to negotiate lower prices, to lack of health insurance for many people. So there is a whole lot of issues that need to be looked into in order to reach a time and moment when we can see affordable drug for everyone. And this is something that many organizations are working on, including UNAIDS and others. And this is an issue that is not going away, and it's one around which it's important to have this conversation. So thank you very much for your very important question.
And final quick point about that too, just getting the medicine to the people who need it most. We haven't talked a lot about adolescent girls and young women in South Africa or Sub-Saharan Africa in particular, but getting PrEP to young women and girls, getting PrEP to injection drug users and sex workers, not just to people who have health insurance or are in the developed world. Another question?
So it's interesting because other than the conversation about medication, a lot of the conversation that we're having right now almost makes me feel like I can close my eyes and think that it's 1986 all over again. Particularly when it comes to stigma and self-guilt and all these various ways that I think are preventing people from getting medication in our country. It's not particularly just the cost of the medication, but in some of the education itself. But it's actually stigmatized. There's a really good article in the New York Times that was published about 2 months ago about this. I don't know if you guys can talk a little bit more about that, because it's funny because it's 2019 and I'm here at Google, which is very progressive, but it's much easier for me to talk about being a 2-time cancer survivor, which I am, than being HIV positive in a place that is a progressive workplace. I can't imagine being outside of this. The stigma affects us here. How does it affect people who actually are in places where, like, small towns, and they have to go to a pharmacy, for instance? And how does that prevent people from getting medication?
Yeah, so one of the things we haven't talked about up here today is the new frontier of the HIV epidemic in the United States, and that's really the South. That's where the most new cases of HIV are occurring. That is where the health outcomes are the worst. And I do think that the very things that Jeremy just raised contribute to that. People in rural communities that don't want to go to the HIV clinic, don't even want to go to an STI clinic, because everybody knows what that building is and everybody knows, sort of who goes to that building. Same thing with pharmacy, et cetera. So there are those factors that play in smaller communities. I think that there's a greater amount of religious sort of stigma around HIV that can exist, particularly in the South. And Jeremy mentioned being more comfortable coming out as a 2-time cancer survivor than HIV positive. Well, I will say that for me, I was super out as a gay man. And actually coming out of law school, interviewing to go to law firms, and it was basically on my resume, right, that I was a gay man, because I wanted to make sure I went someplace that was comfortable. But at the same time, I was HIV positive. I was not talking about the fact that I was HIV positive. That was not evident on my resume. And, it took me several years at my law firm. I was at a law firm before I came to Lambda, before I felt comfortable enough to let people know. And I was doing the AIDS life cycle out in California, and that was how I let people know. But it was the fact that I had gotten to a place where I felt like, well, now they know me, And so now they'll have to integrate this piece of information into who I am, which was a much different thing than going into a place and just being out about your status. So, and we talked about this a little bit before we came in. Coming out about your HIV status is a continual thing. It's not like you had your coming out. I am out on the website for Lambda Legal. It's all over the materials, et cetera. And yet I come out to people all the time. And every time I meet somebody new, there's that coming out process. So it's a continual challenge.
And to that, it's funny because I was on Oprah. I thought, well, this is going to take care of it. I'm never going to have to tell anybody this again. And apparently not everyone knows it's Oprah. So plus it was a long time ago. But I had been in a similar situation where a lot of people knew my status and it was very easy for me to talk about it. And then I moved to rural Virginia, which isn't quite the deep South, as you were describing, but it's different. And I was in a car crash and was in the hospital. I wasn't badly hurt, but I was bleeding and I sat there for hours. And I waited, and this cop came in, and he said, "How did it happen?" And I started to describe the accident. He said, "No, I mean the AIDS." And I had all of these papers in my car. I was moving my office from Paz down to Washington, and my trunk had exploded. And so all the things with me on it, with HIV, everywhere all over the highway. And all the EMT people had been picking it up, which explained why no one had come into my hospital room. Awful. So I marched out there and I was like, "Can I get a Band-Aid or some, bacitracin or something in here?" And the nurse apologized. She said, "I've just never seen anybody with HIV." I was like, "Well, you went to medical school, so get in here and get me a Band-Aid because
right. I mean, that's among healthcare workers, right? These are folks who are supposed to be educated about the latest, and so it's so frustrating.
It's frustrating, but I do think that people with HIV do need to educate people about how to treat us and help people understand that this is just a medical condition. It is frustrating and it is demeaning when it happens. But in Africa, how do people deal with it there in terms of disclosure? I mean, I've been in lots of different parts of the continent. In some places, I feel like the stigma is less because so many people are living with HIV openly. But other places, it's just as bad as it was in the early days.
Clearly, the challenge of stigma and of discrimination towards people in HIV is everywhere across the globe. But we have some very powerful examples of communities, of group of people in HIV coming together to challenge stigma and discrimination. They were very early in the HIV epidemic in the country of Uganda. There was a fantastic group of people in HIV and their allies, their families, called TASO. This group came together, provided self-help, organized peer conversations for people living with HIV, provided a sort of support that was needed when there was not even the beginning of a national HIV response in Uganda. And this group has helped develop some of the approaches to supporting people living with HIV, to contributing to empowering them, giving them a sense of self-worth that is so important. And we have similar such examples across the continent and many places across the world. So people in HIV, again, are a critical part of the equation to address these issues of stigma and discrimination. But that will not be enough. Governments also have a responsibility to address stigma and discrimination. First, by dismantling this curtain of laws that clouds the response to HIV. These are the discriminatory laws. These are the laws that allow for HIV criminalization. All those need to be dismantled to create an overall environment where people feel safe, protected, and respected. But also, there are a number of things that can be done in healthcare settings, for instance, to ensure that people understand the duty to treat, including healthcare workers, that they don't have stigmatizing attitudes towards people with HIV. There are things that can be done in the judiciary to ensure that judges understand and prosecutors and others and policemen understand what HIV is about, understand that stigma is not warranted, is ineffective, is dangerous for public health. And so there are a number of things that can be done. And at UNAIDS, we, together with other UN agencies, we developed and launched recently a global partnership for ending HIV discrimination. We call it the Global Partnership for Zero Discrimination. And it is a partnership that recognizes all the good things that are happening across the world, the good programs by self-help group of people living with HIV, the training for healthcare workers that is being done, the training for judiciary, and we put all these programs into a package of 7 interventions that countries can put and establish to help address stigma and discrimination. In countries where these are being done, those 7 programs, we are seeing an impact in the reduction of HIV-related stigma and discrimination. And I will encourage more countries to do so, and I will encourage different people in different parts of the world to look up those programs, to talk about them, to advocate them, and to see that these become more practiced in various parts of the globe.
And we're almost out of time. I just want to mention one thing that you said, which was the faith community, and the 2 things, and the family. The importance of the support of the family and the acceptance of however you define your family. Having people close to you understand your disease, understand your needs as a person living with HIV. A lot of times people don't know what to do or what to say because it's not an acute moment often. You're living with a disease that's chronic, but at any given moment, if you did stop your medication, it could become deadly. So it's this weird duality where you're basically okay, and I can do everything that I could do before I had HIV, as long as I get my medicine.
That's right.
But that's a very fragile thing. Communities of faith have played a big role, in particular in the developing world, but also here in the United States. We've had a lot of different leaders of different faiths standing up to defend people living with HIV. Maybe you could both talk a little bit about that.
Yeah. No, very clearly, in the early days of the epidemic, when stigma and misunderstanding and blame was rife, it was very difficult to engage faith leaders. But what we've seen, whether it's here in the US, but in different parts of the world as well, is that with knowledge and understanding and this sense of reaching out to the other that is so important in the faith world, we've seen a number of faith leaders coming forward, whether it is in Muslim countries or in Christian countries, in different parts of the world, faith leaders have stepped up to the challenge of HIV, some of them speaking about acceptance, about dignity of people with HIV. I traveled to Morocco a few years ago, and I met with my colleagues doing fantastic work in Morocco. We went to meet with religious leaders. They have an institution of religious leaders, and one of the head of that institution has been one of the champions for the acceptance of people living with HIV in Morocco. And that institution even supports access to harm reduction services for people who inject drugs. This is a fantastic example of leadership by the faith community. In different parts of Africa, faith institutions are actually providing access to services, to HIV services. Faith organizations run healthcare facilities in different parts of middle and low-income countries, and they do so with a tremendous understanding of and value to human beings. And I think these should be recognized. So I think around HIV, what we've seen, and I think for me that is so powerful, is that somehow the challenge of HIV was able to breach certain divides between those who believe and those who don't, between those who pray for Allah and those who worship Jesus. And this is fantastic. And this is something that we need to keep.
I'm afraid that Patrick should have gone second because I think that there's a duality, right, within the communities of faith around this issue. And I think it's always going to be a tough one. And there have been great HIV ministries developed by various different denominations. And at the same time, there's just not a sex positivity within those communities. And so while they're willing to sort of accept people living with HIV, they're really not willing to accept the whole person. And so there's still shame and blame around, I think how you got it is still there. And until we have more sex positivity, and this is not just in communities of faith, but it's across, the entire United States, right? We don't do a good job in sex education because we are so squeamish about sex and talking about it. And so we've got to break down and get rid of some of that stigma so that we can just talk about these things more freely.
And just one quick thing, and then I think we'll turn back to Jeremy to close. But, when I was at Pause as the editor before I came to the UN, I would get calls from young gay black men in the American South who said, why didn't the grown-ups tell me I could get this? Newly diagnosed, calling me up, I've never heard of this disease. And I know that sex education and how we deliver it at what ages to what people is a sensitive topic, but surely as adults, we should be able to warn children and young people that there are health risks that they should be aware of. There's got to be a way for us to do that. I mean, but on your squeamishness on sexuality, when I came out to my community in Princeton, New Jersey, someone recommended that I have a member of the faith community come with me. So I had a gay ex-priest who was gay, who came out as being a gay man. And so we were up there together and we spoke, and there was this long silence. And then one of the most elderly women in the community stood up and talked about how she was still sexually active and proud of it at her age. And the whole room erupted in this very healthy conversation about sexuality. Everybody wants to talk about it, they just don't know how, and they're not given the license to do so.
Right.
So I agree that, part of all of this is, about becoming comfortable with things that really shouldn't make us uncomfortable. Human sexuality is part of all of our lives, hopefully, and it's how we all got here. So I think that but you make a good point about the faith community. We need to accept the whole person, not just the diseased part of them.
That's right.
But let's thank everyone on the panel for being here, and